I'm going to call the meeting to order. We have a quorum.
I was having issues with my,
You know, we were gonna head the second week in January
We're live. We're
We've
live.
all received the minutes. Any additions or corrections? Is there a motion to approve?
So moved.
Second?
Second.
All in favor?
Aye.
Aye. Opposed? Minutes are approved. Health officer report,
Yes,
Dr.
thank
Bales.
you. Okay, well, during viral season, I like to give you updates with where we're at with flu and COVID. So currently, influenza-like illness statewide is still minimal. This is below levels at this time compared to the last couple of years. So that's a good thing, but you certainly can expect a surge here between now and the end of March. COVID is on the rise a bit. Wastewater samples statewide appear to be rising, but actually still below peaks that we saw earlier in the year in June and March. So this illness being less seasonal. Rates of hospitalizations and death from COVID currently and over the year, even during those peaks, still incredibly low. So that's a really good thing. As we're past Thanksgiving and we're going into our next holiday season, or still, I guess, technically in the big holiday season, respiratory viruses like to move about in families and friends and gatherings. So things you can do to stay healthy. Number one, hygiene. Cover your cough and or your sneeze, and we prefer the elbow method, right? If you're not going to be able to wash your hands right afterwards, so that you're not spreading it on things you touch. Wash your hands frequently. Washing your hands is preferred over hand sanitizer, but if you aren't able to do that and you have hand sanitizer, at least needs to be 60% alcohol to be effective. And then clean frequently touch surfaces. So I know when I go into the ER and sit down, I clean the desk, the keyboard, the mouse, the phone, everything I'm going to touch that last doc just left. So definitely clean your frequently touched surfaces. And of course, I'm like a broken record, get your immunizations. So flu is recommended for everyone 6 months or older on a yearly basis. COVID is an individual-based decision-making, but is required or recommended annually. And then RSV, if you are over 75 or if you are between 50 and 75 and you have a high-risk condition like chronic heart and lung disease or a weakened immune system, you should get an RSV vaccination. That currently is not recommended annually, it's just once, but they're still investigating how long that immunity will last, and so currently it's just one time after that age frame. And then just to change topics, for a second, December 1st was World AIDS Day. So I just want to remind everyone that we provide HIV testing and treatment at the Wayne County Health Department. We also can provide referrals if needed to infectious disease, and we provide PrEP, which is pre-exposure prophylaxis for those who are in need. So that's all I have for you today.
Thank you. Any questions? Okay. Move on to clinical service report.
Alrighty, to go over some of our November numbers. TB testing, we still are staying pretty high with that. We tested 19 in November, but we did just bring on another contract to do employment testing. That's something that we do for right now, about 4 different organizations. So every time they, mostly like home health type situations or at home, if they need pre-employment testing for TB, we can handle that, and we can do billing for that as well. Lead for last month, we had 2 home visits. Vaccinations, we saw 70 kiddos, or we did 70 childhood vaccines, 246 adult vaccines. We did 5 off-site clinics and 2 homebounds. So we're staying busy there. Our STI testing, we did 36 HIV, 36 Hep C, and 36 syphilis, as well as 33 gonorrhea, chlamydia, and then fewer numbers on the TRIC BB, providing urinalysis now with Rachel on board. And she was also able to do 2 pelvic exams, and then we did testing for Hep B, herpes, and 7 off-site testing clinics. So we're still staying busy on those as well. For treatment, we are seeing an uptick in gonorrhea and chlamydia, which we did treat a couple of both of those last month. For therapy, with Rachel on board again, we were able to do PrEP, a couple Hep C cases for private insurance, and then birth control as well. So we are seeing those individuals interested in those services. We've had several come in for STI testing, individuals that were able to say, oh, would you be interested in talking to our provider for your annual exam or for birth control, and have been able to get those on the schedule. So we do have several coming up on the schedule. To touch on our FEMUR numbers, we had a strong month with providing support. That's our fetal infant mortality rate. So that's Cynthia Blue. She handles all of that for us. She was able to provide 250 individuals with safe sleep education, 119 referrals for service, and 12 pregnancy test individuals. They went to one event and saw several different organizations there that we were able to provide information to. They were very excited to be able to see that we could do the public exams and provide birth control now too. Starting last year, we brought back doing our county blood drives. We held 3 in 2025. We just finished our last one last week. With that, we had 56 whole blood donations and 2 double red donations. If you're unfamiliar, a double red is when they actually take 2 units, but they give you your plasma and platelets back. So for our total donations for last year, we were able to impact potentially 186 lives. So thank you to the county employees that participated in that, especially the highway department. He always makes time. The snow held out and came a couple days before, but he always allows his employees to take time to come out for that. We do have 4 scheduled in 2026, with the next one being January 29th. So if anybody's interested, let me know and get you on the schedule for that.
Who do you do that through? Do you use the Red Cross or do you use another?
No, we use Versity because they actually provide the blood locally. So they're the ones that provide to Reed, and they're actually out of Dayton, but they do provide locally. And then you might have seen, if you followed our Facebook page, we recently participated in some county parades. We were in Cambridge City, Richmond, and Centerville. We had a great time. We got a very good response. A lot of people recognizing the party bus, as they like to call it. I don't know what kind of party that is.
It's a different kind of party.
It is. But it is nice to get out. People be able to recognize us in public. So I appreciate everybody who helped with that. Case management, we're right around about 128 active cases, our typical higher with the lead. We're seeing our Hep C come down because we are able to get in contact with those individuals and try to get them in for treatment. And then our normal animal bites, stuff like that. So other than that, I think that's about it. Questions?
Any trends among those testing, or is it pretty stable?
For STI testing?
Just in general, the things we're testing for, are there any trends?
We're seeing a lot of gonorrhea and chlamydia being passed around. Individuals will come in, send in partners who are also testing positive, who have had multiple partners. So we are seeing
How about
that
syphilis?
come back. We haven't had any, we had some 2 months ago in September, I believe, but we haven't seen any in the last month or so. But usually in the cold months, we do see our numbers tick up a little bit with some of our STIs.
Thank you. Any other questions, comments? Can you go on to environmental service report?
As far as housing and pools and spas and tattoo and eyelash, there's really nothing to update for that. For food, we are finishing our second half inspections. As of today, I think we have 9 establishments left to check. Luke Reimsnyder and Angela McDaniel are both in the process now of being standardized with the new food code. I think we will actually be only the second county in the state to have more than 2 people standardized with the new food code. And then Wawa is good to go. They passed their inspection, but they won't open until January. As far as septic goes, we still have 3 that are in failure. One is actually going to have a dye test this week, and hopefully they pass, and that'll take one off off. As far as animal bites, last year we did 112 investigated. This year we did 177 so far. I think a lot of that is getting more reports from Richmond Police Department. As far as lead, we did 6 risk assessments last year, and this year we're already at 15. And then emergency preparedness, we're actually going to be hosting a tabletop exercise this Thursday at the fairgrounds for cybersecurity. So if anybody's interested in attending that, that's going to be at 1 o'clock at the fairgrounds.
Are mostly animal bites dog bites or?
Most are, yeah, cat or dog bites.
Other questions? Comments? Okay. I think you're on, Dan.
All right. My information is not as fun as theirs. Mine's all contracts and money. I did send out a calendar invite to the board members as far as the tabletop this Thursday. Is there anyone that did not receive that invite? We're working in between 2 email addresses right now. The county is switching our domain. So we're going from the co.wayne.in.us to waynecounty.in.gov. So all of us at the health department and across the county for that matter are working with 2 email addresses. And some things are working, some aren't. Some attachments I send out, some people can open, some people can't. So I will do my best to follow up on those that I do send out. So the first order of business is the Health First Indiana contracts. The board approved the 3 proposals for Bertha 5, Bridges for Life, and Reed Hospital. They approved a 30% reduction, and all proposals agreed to take that reduction. So we're moving into the contract phase of it now. The contract is essentially the same contract that we used last year, with the exception of taking out the changes for the legislation this year as far as tobacco cessation and the U.S. citizen factor. Chris has reviewed the contracts and said they're good on his end to move forward. So the first one we're going to go over is Birth to 5. And their final reduction amount was to $58,852.65.
I think you all received those contracts before. Are there any questions or?
This is their budget laid out here. If you can see it, how they presented it with the reduction in funding. It's still going, most of it going to personnel, then the remainder going to supplies.
The one thing I noticed going through all of them on the checklist, there's an awful lot of reporting just based on how many did you do or that. Or the report's going to contain the results that they're trying to achieve, like for instance, Birth to 5 had quoted some certain percentages and they wanted to show that they were improving. And is that going to come through the report, or are we going to use statistics to try to show their impact, or how are we going to do that?
So the state does not make that a requirement as far as they use statistics and numbers. So every time they report to me, I input numbers into a data tracker, and then they pull that up. But on the side of each reporting mechanism, there is a spot for Birth to 5 or any of the contractees to put certain things in if they want to better identify what they've done. Was it a community event? Was it daily activities? Things like that. But there's nothing built into the system that identifies whether they're improving their metric. The state handles all that.
And I think the problem we have there, it'll be a couple of years before we know.
Most definitely in all these programs.
Yeah.
Well, at least, right? At
Yeah,
least a
at
couple
least
of
a
years.
couple
If you
of
think
years.
about improving life expectancy and,
Right.
those kinds of things.
Mortality
Yes,
and-
it's not going to be a
Right.
easily measurable endpoint, but one that's worthwhile nonetheless.
Right now, I don't have internet connection, but at the next meeting, hopefully I do, and I can show you where to go on the public website. There's a couple places you can click, and you can get to a point to where you can pull up a PDF form that shows you everything that Wayne County has done and the partners have done. All the data that I input, essentially, it's broke down into one PDF form, and you can view that anytime you want to. And I can show you how to get to that next time, or I can send you the link via an email to get you there.
Any further questions or comments? And Mark, do you need to abstain on this?
That's up to you.
Are you still on their board?
I am.
I think you should abstain on this vote. I'd entertain a motion to approve.
I'll make a motion.
Second.
All those in favor?
Aye.
Opposed?
All right, we'll move on to Bridges for Life. With their 30% reduction, it dropped their agreement price down to $64,200.65.
I noticed that when the county using their opioid funds, said they were funded fully.
Yes, between our money and their funding. Now, I don't know, as far as the opioid funds, if it's going towards the same programming that they've done, if they're operating two different programs out of that. Reed Hospital also received opioid funds, but they're not in relation to Health First Indiana. It's two separate programs that they're operating. So I can't speak to that on Bridges for Life with the money that they received for
But you don't
that.
see any reason to make an adjustment on Bridges to Life.
I do not, no. No. I think what we agreed to is appropriate.
Other questions? I'd entertain a motion to approve.
Move to approve. Second.
All in favor?
Aye.
Opposed? Contract approved. Reed Health.
There it is. And the last one is Reed Health, and with that reduction, it dropped down to $76,946.71. I'll get to their budget. I think I bypassed it.
Questions, comments? Or a motion to approve?
Motion.
Second?
Second.
All in favor?
Aye.
Opposed? Approved. They still need to go to...
They'll have to go to the commissioners for final approval. There's a spot, I've got it earmarked on each one of the contracts for your signature.
Sign them.
Okay. And then they'll go to the commissioners tomorrow for them to take a look at. Let's see. We'll go into the financial side of things, I believe. We did receive back $6,000 from ANDA, their medical supplies provider, with the help of Chris. That was the one I told you that we wanted to close the account, but they refused to send us a check. They'd only agreed to an EFT transfer. We didn't want that. We wanted a check, so we didn't have to go through all the steps with the treasurer's office and the bank and things of that nature. So Chris got that approved for us, and we did receive that payment, and it was deposited. We are also waiting on a close to $10,000 check from Pfizer, and that a lot of that is either credits or returns that we have. So we should be getting that back before the end of the year to get that deposited as well. So if we go here to the budgets, as we close on the end of the year, next week is the last week I'm able to submit claims to the auditor's office. So these dollar amounts will change a little bit, but not a whole lot over the next week's time. So if we go to the first one's payroll, it's the county fund. There's currently right now, that balance isn't correct because I don't mess with the payroll, but it's a lot less than that, let's say that. So, but Health First Indiana, we're sitting at the $318,788 as far as the cash balance goes. We have $104,000 left in contracts that we have to pay out, approximately $3,000 in operating cost as far as like hazardous waste pickup and things of that nature. And then $5,000 in salary and fringe. Our medical assistant, is funded out of this particular fund. So we're going to be about $110,000, $12,000 shy of that 318 mark by the end of the year. So we'll carry over about what we intended to, about that $200,000 mark that we earmarked for contracts and Health First Indiana partners next year. Health Maintenance Legacy Fund. This is a fund that was replaced by Health First Indiana. We have now exhausted that fund and it has a zero balance and will not renew in '26. Health Donations. This is a fund that has carried over from when we used to be the old health department in the other building, so forth, so on. It has a very small balance of $4,144 in it. My intention for this fund is to use it to operate our TB program. So if we have someone test positive for tuberculosis and we have to isolate that person, we have to put them up in a hotel and we have to provide them food service. Essentially we have to take care of them. So we had nothing in the past earmarked for that. So I've set this money aside to do that in the event that we do have someone test positive for tuberculosis. Health Trust Legacy Fund, 4916. That is another fund that was replaced by Health First Indiana, and those funds have now been exhausted and it will not renew. 9101 is an emergency preparedness grant. This is a reimbursable grant. It's what we're using to fund the tabletop exercise this week and a few other exercises over the next year or so. It ends on June 30th as its cycle. It goes from July 1st to June 30th. So they reduced that. There used to be a $25,000 grant every year. They reduced it to $20,000. Community harm reduction. Get rid of this. There we go. This money is, we won't spend any more of it this year. We'll carry it into 2026. And this money will help us run the harm reduction program and pay for medical supply costs, hazardous waste disposal, anything to do with harm reduction. This is the fund that previously funded the syringe exchange program. So there's a balance of $18,141 in that fund. 340B fund, this is clinical services fund. Balance of $636,000 approximately. There's a cash balance in the fund. This is what's appropriated right now. There's a cash balance of about $750,000. That's about 150 or so thousand has not been appropriated. But this balance will depend on patient volume and how much medication we have to purchase for that program. Rachel, our physician assistant, is funded out of this fund as well. COAG fund, this is an old grant that had a balance left in it, and it has $108,618 in it. We do have about $25,000 left in contracts and about $2,000 left in operating costs before the end of the year, so that balance will go down by that $27,000. This will be used to pay, let me back that up a little bit. So next year, we had a part-time nurse. She's been employed with us for a few years now. She resigned, so I've been asked, I'm going to reclassify that position if commissioners and council approve it. I'm going to try to reduce it from a nurse to an MA. That position needs to be an MA. It doesn't need to be a nurse. They will help G out in outreach, and they will help us in vaccine clinics. So we only need them to provide vaccine shots and help us with our clinics. So there's no reason we need to pay a nurse to do that. We can pay an MA to do that. So if that gets approved through both bodies, then I will use this fund to fund that position. So it would be a part-time position. MAs, I don't want to say it because it's not been adopted, but next year, with whatever is adopted on the salary ordinance, we'll bump that pay up or leave it the same depending on what's passed on the salary ordinance, and then we'll pay the fringe out of this fund. So it'd be about, give or take, $20,000, $25,000 maybe. And then the rest of it, I will try not to touch. I will try to use the 9181, and which is the COVID reimbursement, and we're about to cover in the 9164, which was the harm reduction fund on the previous page. I'm going to use those two funds to try to operate the health department outside of Health First Indiana. That's office supplies, education, training, everything to operate that. In the attempt to, so we can carry some more over into 27, because 27 is going to be a rough year, I believe. I will do my best. 9175 is the FEMA grant. That's a reimbursable grant. That only covers the salary and fringe for the FEMA coordinator. 9181 is the COVID reimbursement. There's about $95,000 left in it, and we will carry that amount over into 26, and again, we'll use that for operational cost. And then 9252 is an expired grant that ended in March of 2025 by the State Department of Health due to funding reduction. There is no balance left on that. Are there any questions on the budgets and what we're doing next year, what we're carrying into next year?
We anticipate that the emergency preparedness grant will be renewed in June.
If they offer it, I will reapply.
But we don't even know if it's going to be offered in June.
Correct. It's, I can't remember. So basically, that's a 3-year grant that the state receives from the federal government. So I don't remember what cycle we're in it. Right now, they call it billing period 1, 2, and 3. If we're in billing period 1, we'll still have 2 more cycles left, so we'll have 2 more years. If we're in 3, then I don't know. I'd have to go back and look to see which billing cycle we're in. But ever since 9/11, it's never not happened. That grant has been available every year, every 3 years in that billing cycle. So I doubt it goes away, but there's a possibility. We don't use it to fund any personnel or fringe or operating cost. Is strictly training and supplies for that training. And we'll start looking for beneficial grants. I'm not going to apply just for random grants so I can get, funds, but if there's any decent grants out there that are not matching, that are 100% funded, then we'll look to see if they're beneficial to the health department and what we're trying to do and the health outcomes, things of that. But yeah, I don't want to operate a bunch of little $10,000 grants. It's going to have to be worth the application, to say the least.
Does the motion for that position, that RN to
Are you
MA
on that
position?
position change, are you bringing that to us next month, or do you need a?
I don't know if I really need to bring it to the board. I never have before.
So that's what I'm just asking. Yeah.
I guess, are you guys okay with me doing that? So this is not a new position, so it was merely refilling what we already had in a sense. We're just reclassifying it down to a medical assistant. So I have no problem, if the board has a different suggestion, I have no problem taking that suggestion and leaving it as a nurse or not leaving it as a nurse.
Well, I assume the fact that we have on an NP or
EA.
EA in place, that reduces, that they take over some of the function of having an RN.
The PA? No, so the PA we have is completely separate. She only does 340B program duties. So if that program was to ever go away, essentially that position would go away as well. So the MA that we're looking to hire that was previously a nurse, if we can get it reclassified, would only be for our daily statutory obligations, to do vaccinations within the clinic or go to community functions to do vaccinations. So
We don't need an RN to do those functions.
no, nor an LPN. Yeah, just a medical assistant or it's a medical assistant. So somebody that's able to vaccinate and draw blood, which medical assistants are.
Given
Nobody do
today's
know.
shortage, I think it also makes sense.
Yeah. So
Dr. Reiner, I would just make the comment that it never hurts for Dan to have formal board support for something that he brings to council and commissioners.
So does anyone in?
I'll make a motion.
Make a motion.
Position change to an MA.
I'll second it.
All those in favor?
Aye.
Opposed? So we recommend that we support Dan on that decision.
I appreciate that. Are there any other questions on the funds or how those funds will be spent in '26? So an update, if you remember, approximately 6 months ago, we reported to Medicaid via a written letter that we had a material breach where we had medication at the health department that had not been distributed, and we brought it before the board. And it was the advice of our 340B consultant to report this to Medicaid, so that's what we did with the help of our legal counsel. So yesterday was the 6-month mark. So that letter was sent out via certified mail. We never did get the receipt stating that it was received, but it was sent out certified mail. And today is the 6-month mark, and we have not heard anything back from Medicaid. So according to our consultant, that's good news. Until they watch this, I guess. Our 340B audit. So in that was discovered that we needed a policy. I sent the policy out a couple months ago and then resent it out last month. It's a long policy. It's got a lot of policies within the policy, but it is, we'd like to hear what the board thinks and potentially get approval today to move forward with that policy. Again, it was drafted by the consultant, and it covers all of our operations of the 340B program, and it also puts into place preventative measures that would prevent something like I just discussed as far as reporting to Medicaid on the material breach. It would prevent that from happening in the future. So with that said, before we get deep into the policy, we'll go into the audit discovered the policy needed to be done. So we're addressing that. So that is number 1 on here. If you remember when the auditor come in, he gave us a list of recommendations and things that we had to do to get in compliance. So one of them was the policy, which we're covering today. So that was number 1. Number 2 requires that pharmacies include submission clarification codes when billing a managed Medicaid plan for 340B drugs. Beth has spoke to the pharmacy that we use, which is Medicenter, and they do that, so we're in compliance there. So number 2 is taken care of. Indiana Medicaid managed cares have varying requirements when carving in. Adhere to individual Medicare managed plans policies when billing these plans for 340B drugs. So some managed plans allow you to bill for 340B drugs, and some do not allow you to bill for certain 340B drugs. So Beth has went through that, and we've discovered what we can and can't do for all the different managed plans. So those, so we know, so we've completed that part there.
That's something you probably need to do annually.
Yes, we'll go through it. Josh will come in, our consultant will do annual audits. He'll come in and do the annual audit, so everything will be done, and of course we'll do internal audits as well. But yes, everything will be revisited every year, including the policy if it gets approved today. There's sections up there for last revision date, any updates will have to go through the board and be approved and signed off again. All 20 signatures, unfortunately, again, each and every year, so, yeah. Again, number 4 is the covered entities, which is us, required to notify Medicaid when carving in managed plans. We've done that through Verity, which is a third-party payer. Number 5 is to amend or terminate the pharmacy service agreements with Phillips to address unregistered locations. We've had a conversation with Phillip Drugs, and there has been a contract letter, I don't know what you'd call it.
Contract termination.
Termination drafted.
He still hasn't signed it.
Yeah, we're waiting on Phillips to sign that. So I talked to Phillips, and they were okay with the termination of the contract. So, and the reason for that is they filled one prescription in a year's time maybe, and they've denied a couple others. So we've had to go through the problem of getting them reassigned to a different pharmacy. There's just not enough volume there anymore. Be beneficial for a small pharmacy like that. And number 6 was to update Opus with Avita. Avita is a contract pharmacy. There are some things there on Opus, Office of Pharmacy Affairs, some inconsistencies where Avita has several locations and the numbers were swapped. So, for instance, if location 1 was 100 South 5th Street and location 2 was 401 East Main, they just had the location swapped on the addresses in the contract. So I got a hold of Avita, and we got that corrected and changed. At that time, we did not have fully executed copies of contracts with Avita, so I had them send me copies of the revised contracts. We have those on file now. And then ensure all program policies are approved under existing procedures for policy approval, and policies have an effective date. And we'll take care of that when we, if the policy is approved, when we sign off on it today, it will be dated. So number 9 and 10 were suggestions. They were not any type of violations or non-compliance. We can get into those at a different time, but he's essentially talking about maybe eventually self-dispensing and expanding programming into 340B program. So we're not quite ready to get there yet, so we can discuss that another time. Are there any questions on our compliance on what he found in the audit itself? All right, so now we'll go through the policy itself. Find it. Is there any particular section of the policy that the board wants to discuss in better detail, or any questions in general on that policy? As we can see, there's several sections here to the policy itself.
There are several references to pharmacy oversight and audit on our part. How are we going to do that?
Through Josh, through his audit, his annual audit every year.
So we'll do that with the annual audit every year.
So what he does is he goes into Verity, which is our third-party payer, and he can access all the pharmacies' prescriptions that they filled, and that's how he audits it, to make sure that they're following procedure.
And then the oversight board, that board reports
To the health board.
But it is, at this point, it's going to be a committee of the department and not of the board?
No, it would be board members. Yeah, so.
Well, no, there'll be board members on it, but
Right.
the way it was listed, it didn't sound like it had to be all the board members.
It does not. So it would be a subcommittee. So it would be Beth and I. It will be Dr. Bells if she chooses to be on it.
They had the members listed, but it wasn't stated whether it was a board subcommittee.
Not fully just a board subcommittee. It's just a subcommittee for the 340B program that reports to the board. So whether you want to call it a subcommittee or a committee, a standalone committee, is just a play on words at that point.
Well, it
But
appears that it's a subcommittee of the board that has outside members. How do other people interpret that?
I look at it as a committee with board members on the committee.
Yeah, there's that, but then it's a committee of the department,
It's the department.
the health department.
So, based off the 340 program. Correct?
Does the
Yeah.
department typically have committees?
Do we have committees? No. I'm part of several committees, but we don't have one committee for ourselves.
Is there any problem with the department having committees that are separate from the board? That contain board members?
I don't think so.
And-
Typical in other functions of government where they have committees
And this
different
wouldn't be,
representation on there.
this wouldn't be a committee to make decisions. There'd be no voting or anything like that in this committee. This committee would come up with recommendations and bring them to the health board
It's
as a
an
whole.
oversight committee.
Correct, yes,
That's correctly best.
yeah.
Yeah. Absolute power, just make sure you're doing it.
Right.
I mean, that's what it's called, oversight committee,
Yeah.
An
right?
oversight.
Yeah.
But it says it reports, sorry, excuse
Oh,
me.
no, I'm sorry. Here's the Health First Indiana Advisory Committee
Similar, yeah.
that you led, that was made up of outside members that were not members of that board, and not necessarily employees of the Wayne County Health Department, and did not vote or, make decisions, but rather made recommendations.
From a legal perspective, there's, I'm not aware of anything that would prohibit the department from having a standalone committee. And if I remember correctly, the initial discussion was about having members other than just board members to provide that outside point of view, outside perspective. So it wouldn't be completely insular, so.
But would that also include, say, a pharmacist or something like that?
Not according to his policy.
Okay.
So right here, I got it pulled up here if you can see it. The Health Department established a threshold of what constitutes a material breach, which is in the policy itself. This is what the board would oversee. So basically, it'd be going over material, any type of material breaches, maintain records of materiality and assessments. Let's see here, see if I can find something else.
Well, it looks like we'd have two layers of oversight, because it looks like this committee would be an oversight committee, but the board would still have oversight on top of that.
The board would have ultimate control.
Right.
The oversight
So it would be a
committee.
dual, double check,
What's the annual
which
on
is
it?
not bad.
Right.
No, that's a good thing.
Yeah, the oversight committee would only be for 340B.
Right.
I mean, it wouldn't have any recommendations or oversight over anything else other than the 340B program itself. So like right here is the material breach policy. So 10% would be our material breach. So that's something the board would meet every quarter or however many times a year it decides to meet. And Beth and I would go over some numbers with you, with the subcommittee, and see what if we have any material breach at all. As long as we follow policies and procedures, we will not have any material breaches, but that would be for that oversight committee to go over with us.
So at a minimum, this committee would have to meet at least once a year after the audit.
Yeah, so he suggested, Josh, our consultant, suggested the oversight committee meet once a quarter. And then we would probably do that prior to or after a scheduled health board meeting. So probably prior to, just in case it has recommendations to send to the board, but
Okay, but that would not be open to the public.
no, it's an oversight committee, no. It wouldn't be an executive session, but not open to the public. Because you're not making any decisions or voting on anything in that meeting.
Other questions about the board? It appeared to have appropriate people listed. we'll probably be asking for volunteers.
So we can establish that committee in the January
Sure.
meeting.
Yeah.
And I know it's one of the problems we've had in the past, and it's addressed in here, is it's returning drugs and drug destruction. Go over that a little bit.
Yeah. So we shouldn't have to deal with that too often because we won't have medication shipped to the health department itself, but I have to find it in here now.
But do we still have drugs that are out there in limbo currently?
Yes. That are not expired, they're still locked up.
So this has a mechanism to resolve that?
Yeah, we won't be receiving the refills. Some have to be sent to the health department, like if we get TB medication from the state or whatever. But we have policies in place for how that has to be addressed, how often we have to try to reach out to the patient, what our protocols are. So going forward, following the procedures, we will not have the abundant supply that we do now.
And of course, there's always a situation where drugs expire,
Right.
and that's addressed, I noticed.
Yeah.
So in that policy, if we don't make contact with the patient we have to make an attempt at least 3 times within a 2-week period, I believe it is. Don't quote me on those numbers here. But it's several attempts within a 2-week or 10-day business period, so 10 working days. If contact is not made with that patient or they don't come in and pick it up, at that point we try to return it to the pharmacy. So in that rare occasion, it is not put on a refill, so there's no chance of that second prescription coming in. But the patient would have to ask for that medication to be delivered to the health department. It's not even going to be offered. We'll prescribe it and it will go to a pharmacy unless they want it delivered to the health department for them to pick up. And if that's the case, they have to sign documentation that they've made that request and that they have to pick that medication up within a certain amount of time or it would be shipped back. So as far as the destruction of medication goes, that's a hard one. I mean, there's RPD does days. There's certain pharmacies that do collections for destruction and things like that. Most of the time in the pharmacies I've talked to, they won't take back medication, even if it's a week old. It doesn't matter. Once it's prescribed and comes off their shelf, they're not taking it back. So then we get into, we can't repurpose it because it's been prescribed to a certain patient. So it basically has to sit there until that point. So that's the reason we don't want it shipped to the health department. We don't want to be responsible for that. But yes, there is a policy on reaching out to the patient on the storage of it. We have biometric locks at the health department that secures the medication. Only a few people have access to it. Does that answer your question? Okay.
Have we maintained a breach record when there's been a problem?
If there is a problem, yes, there will be a record of it. So,
That's the sort of thing that would be reported, I assume, to the committee on a quarterly basis.
yeah. If we get to that 10% threshold, according to the policy, yeah. So, we're hoping the committee would catch it, or we would catch it prior to that 10% breach. But even if there's a breach that doesn't reach that, we're going to address that breach right offhand. But as long as we don't have too many prescriptions shipped to us, which that's our ultimate goal, we should never have a breach. That's the only way a breach is going to happen, essentially, is if it's shipped to us.
And then you talked about there'll be internal audits in addition to the annual audit.
So we'll do like inventory control every month for the medication that we unfortunately do have. We'll do an audit on that. There's a couple different things we have in the policy as far as on the chart, making sure the charts we had an issue with charts being documented in, to make sure the charts are being documented. There's other things in there that we would follow up on with different audits. Maybe audit's not the correct word,
Just
but,
our controls, we've implemented
yeah, internal controls.
internal controls to make sure everything is logged, everything's in the EMR. Any medication we have, there's a log, there's a 2-person sign out, in addition to the biometric that has a record. So continuing to just check those things and make sure they're being used.
And then about ensuring that the staff are trained. I mean, I'm sure it's a very small program, so I realize there's not many staff to train, but kind of a documentation of, we reviewed this policy and, trained on all of these, areas to ensure.
Yeah, after
compliance.
it's approved, we'll make sure that all the staff are aware and we can get sign off that they've reviewed it.
And that's something we're trying to do as a whole, as a health department as a whole, is there's no formal training program, whether it's environmental, medical, it doesn't matter. There's no formal. So in the world I come from, there's always a policy or procedure or training, so there is one now for environmental. That was created, and the first person it was used on was our septic inspector, which is Tim Croucher now. And the goal is to get that onto the medical side too, to have everything from billing to check-in to each and individual program that we operate, everything I do, whether it's paying claims or anything like that, I've tried to put into a document or a PowerPoint, so somebody can go in after, if I was to wreck on the way home, Beth could take over tomorrow if she needed to. So we're working towards that, to have
Just
a
like, don't
training
do that.
procedure.
Don't do that, Jennifer.
Well, along with education, there's a mention for board education, so what did you
Yes.
have in mind for the board?
340B University.
What?
So we don't become consultants.
Does that pay well?
340B University is a website that anybody can log on to. It's free. I think it's put on by Opus, maybe. I may be wrong on that. But if you have a question, you can literally type it into the search bar and it will bring up some kind of program you can use to get any information. It's definitely more knowledgeable than what I am. That's the whole reason we hired a consultant. This is a very, very complicated program.
So you're going to send us that link?
I can send you that link, yeah. 340B University.
Review the contract, right?
Pardon?
When you review this contract that you receive the policy, it has embedded videos in it that you can just click on.
Yeah.
And it starts your education
Yeah.
of the 340B
University. Yeah.
Yes. And they're very easy to consume, so.
Yeah, if you did receive this digitally, which everybody did, this policy and procedure, you can come up here to like the purpose, or let's go definitions, and you can hit control and click on it, and it takes you right to the definitions, or, all the links are working links last time I checked, so forth, so on. There's a lot in there, yes.
Yeah, like this page is about 3 or 4 things. It's not-
What page was that?
5. There's like an animated video.
Well, I don't have internet connection, but I would show you. So, yeah, every one of these blue bars is a link, but.
Now, we already have to do inventory separation between private pay and Medicare. Well, certainly Medicaid.
Inventory for,
Well, for the immunizations, we have to keep
Oh, yeah.
separate inventories.
yeah.
So this will add a third category that we have mentions keeping a separate inventory on 340B medications from their other non-340B medications.
Which it already is separate anyway, because the 340B medications are cabinet with pills. Our others are just the vaccines that are separated between. So it's already,
We already have the capability of separating.
yeah.
Other questions, comments? There's several components to this. I don't see any reason we couldn't just do them at large and do them all at once. So I would entertain a motion to do that.
So that would be to approve the 340B policy, correct?
Yes.
Policies, it's a
So moved.
Second?
second. All in favor?
Aye.
Opposed? Approved. Does this also go to the commissioners?
The policy does not, it's internal.
It's, okay, departmental policy.
Yeah, they're more than welcome to read all 100 and some odd pages if they want. So I'll be more than happy to ship it to them.
We're almost there.
No, I was impressed by how you have studied this thoroughly and
Yeah.
accept your.
Yeah, not so much. Yeah, anytime there's a large policy like this, if you want to shoot me your questions in advance, it'd be much appreciated. I could study that. We're doing a 5-pager, no need for questions in advance, but
You're doing great.
I appreciate it. All right. So at this point, unfortunately, Emily and Roger have to be reappointed or recommended for reappointment to the commissioners, Roger County Council and Emily County Commissioners, because their replacements expired at the 31st of this month. So,
And they both said they were willing to serve another term.
yeah.
Great.
Yeah, via email, they both agreed to serve. So, for another term, so I would ask the board to make a recommendation to the commissioners and county council to reappoint Emily and Roger to the health.
Do we need separate motions?
Probably because it's one to the fiscal body, one to the executive body, yeah.
Okay, that's, entertain a motion to, for Emily, and Emily should abstain.
I'll second that motion.
All in favor?
Aye.
Opposed? And now I'd entertain a motion for Mark?
So moved.
Roger.
Roger, I'm sorry.
So
Roger.
moved.
Roger. Sorry, we did Mark last year. Roger should abstain. Motion?
So moved.
Second.
All in favor?
Aye.
All opposed? Thank you for being willing to serve another term.
All right, and the last thing I have is the credentialing proposals that I'd sent out to the board. These proposals are just that, they're just proposals, they don't have to be signed off or anything like that. If the board decides they want to go with a certain proposal, then I'll take it to the commissioners and see if they want the same thing. And then at that point, I'll make contact back with the company to have them do a formal proposal with a contract. Then we'll go back through the same process again. But we're having issues with a company called Certify. They're the company that handles all the credentialing for us. They are a subcontractor of Athena, which Athena is our medical records system. It's pretty a simple process. Last year, we approached Athena because we were not getting bills reimbursed by private insurance payers. And part of the problem was the credentialing part. Our providers and the department as a whole wasn't properly credentialed, so we went on the path of finding out how we could get that done. And Athena said, hey, we have this subcontractor called Certify. So we went through this process with the proposal and all that good stuff to have Certify come on. And Certify was done pretty well to start off with, and then all contact seemed to stop. So anytime I have to make contact with them, I have to go through a link that's just like a little contact form. It pops up, I have to type in all my information, and I have to hit send, essentially send it in an email. And then I get nothing in response. There's no phone number or direct email that I can use to contact anybody with Certify, and it's super frustrating. So I reached out to Athena and basically asked them what was going on, and was there anybody that I could contact to address the issue? And they said, well, we're glad you reached out because we're having the same issues, and we're canceling their contract on January 1st. So as of January 1st, we will not have a credentialing company so I began the process of reaching out to different companies to see what they could offer for us. So the first company I reached out to is the AC Billing and Credentialing Specialist, and that is here. So this company is operated by Allie, is her name. She is a physician, and she started this company due to her having the same problem when she was in practice, is what she told me. So this company does billing and credentialing. We are only seeking out the credentialing side of things. And in here, so we get into some of the costs. It's $350 per MPI, includes groups or individuals. We would have 3 MPIs. We'd have the health departments as a whole, which the MPI technically belongs to the auditor. We'd have Dr. Bell's MPI and then Rachel's MPI to credential. And then $45 an hour after onboarding for further tasks. So this could be anything from updating Medicaid or updating United Healthcare, so forth, so on. So basically right now, Certify, well, they're not doing it, but they were supposed to. Once the provider was fully credentialed, then they would go in monthly and make sure that that provider didn't need any updates on any of the payees basically at that point. And that's what the $45 an hour is how she explained it to me.
So Dan,
Yes, sir.
on the per NPI, so that 350 times 3?
Correct. Yep. And then the company is based in Ohio, I believe Cincinnati. It's either Cincinnati or Columbus, Ohio. But their offices that they operate out of are in Mount Vernon, Indiana. So they are essentially local. Even being in Ohio is local. Certify doesn't have a physical building or a physical person in the United States. So that could be part of the reason for the lack of communication. We would have weekly or monthly calls with our credentialing representative. That would be included in the cost. There's no additional cost for that. And then on top of that, even though that we're not seeking any type of billing assistance right now, if we had, like right now we're having managed health service, we're having a hard time getting them to pay their claims. If we can't get that answered through Athena, we can contract an hour visit with this company for $30, and they would help us through that process as to why we're having issues with managed health services. But they'd go through NEPS and PICOS and CAQH, which is all different federal places where physicians and providers have, credentialing and things like that, but they go in and they make sure everything's correct. We are still having issues with our MPI being mixed in with WellCare's MPI. So I get documentation and emails all the time about my FQHC status. And I don't know how many times I reach out and tell them, wrong person, it doesn't matter. So this company is telling me that they could fix those issues. So on the other hand, Athena did reach back out to me, and I think I sent that to, it was a little late. Southern is the name right here, yep. And this would be another subcontractor, Athena, that is based here in the United States. They promised me that. They also promised me that I would have a person through Athena that is dedicated to solely credentialing, that I would have a point of contact at all point in time. That's my biggest thing. I want to be able to reach out to someone and talk to them whenever I want to. So they're both companies are promising me that. But this is how it would be. Practice initiation fee would be $1,000, which we're already established, so we would not owe that. A new provider enrollment, we would not have to do that for Dr. Bells, but I believe we would have to do it for Rachel because she's not far enough into the credentialing process for them to consider her an existing provider for us. Us as the health department would also be considered existing. We wouldn't have to go through the new provider enrollment. So we're looking at $800, $2,000, $2,400 right off the bat to get things going with them. And then the monthly updates would be $60 per provider. So whereas the other company was about $45 an hour, which is, they're saying an hour for each provider. So $45 an hour per provider. So the other company is a little cheaper. There's advantages and disadvantages to both. The private company out of Ohio that's based here in Indiana, we would have most definitely direct contact with that company. There would be no third party involved, which would be Athena. So if I have a question, I can call directly to the credentialing company. The downside is we're dealing with a new company and we're going to have separate billing now to deal with. If we go with Athena's subcontractor, which is Sutherland, it's going to be a little pricey up front, but the $60 per provider would be similar. So the maintenance on that would be similar. But the ease of this would be us just reaching out to Athena once we get approval from both bodies saying, this is what we want, here's the documents, and they take care of it from there. They add it on to the bill that I already pay every month, and they would provide me a direct contact to that company through them. So I would not be able to speak to Sutherland directly, but I would have a person at Athena that I could reach out to based on credentialing only. Are there any questions?
Which do you feel more comfortable with?
Comfortable, or what do I think is the best option? That's a hard question. Comfortable, I feel it's probably more comfortable just to let Athena to take care of everything, from the get-go. Let them add it to my bill. Let me just, I think I am more confident in the private company taking care of what our actual needs are and straightening things out. I like the ability to contact them directly and not have a third party to go through. But the ease of the transition would definitely be easier with Athena, but I think we're getting more bang for our buck if we go with the other company. That's just my personal
And
opinion.
if we sign a contract, it would be for how long?
There is no sunset dates on them. It's basically if you decide you no longer want to do it, you just reach out and say, we're done. So at least in the proposal, she didn't put anything in the proposal, and that's how it is. Anything with Athena, anything that you sign through Athena matches your original contract with Athena, which I don't have the original contract with Athena. That copy got lost somewhere back in 2020, I guess. But from what I'm told from our rep Henry, it is whenever we want to cancel, we can cancel. We want to get rid of a program, we just get rid of that program. There's no early termination fee or anything of that effect with Athena. So Sutherland would mimic that. As did Certify. So,
How happy are you with Athena on the billing side?
no, not happy at all. I would drop Athena instantly if I could, but it would be it would be such a heartache to do that. I mean, if I had the magic wand, I would switch over to Epic, which almost every provider in this area and across the United States, for that matter, uses Epic. But we still have billing issues, like I said, with managed healthcare systems. That should have been resolved a long time ago, between our rep and stuff. I don't know. I mean, it's just not a very good company to work with, and I can't speak I can't speak to Epic, I've never worked with Epic either, but everybody tells me that Athena is like number 6 on the list when it comes to medical record systems. So I don't know if that's what we went with back then because it was cheaper. I don't know why they chose it.
Epic wouldn't look at anybody that was small.
It's
For a
possible.
long time, that you had to be a certain size. I mean, that's one reason Reed didn't go initially with Epic, was the way it was set up.
And I don't know if there's a way to partner, let's say, with a larger organization to just add our, if there's a way to do that and separate the billing and stuff like that, probably not. I mean, that would be ideal.
We initially tried to do that with Community, and it didn't work out.
Yeah, so anytime you add another party into the mix, it's typically not a good thing, but yeah, Athena is not user-friendly. It's just not a good system in my opinion, and I think on the medical side for Beth as well, it's not very pulling a report is horrible. I mean, just trying to pull a report from it, you got to build your own reports, and unless you're very familiar with their terminology and stuff, it's not even medical terminology, it's their terminology. It's very hard to pull a report, but.
And they're just not to the point where we can say, like, sign in electronically when somebody gets there, that's something that we wanted to introduce. Well, we have a certain form that everybody needs to complete, and as of right now, they're not to the point where they can take that form and integrate it into that electronic sign-in. So we still have to use paper because they can't.
So why would you want to dump all your eggs in one basket?
Yeah.
Right.
I think from what I'm hearing is AC is going to give you the support and service, and it is cost effective. And what I hear, I would have to make a recommendation to go with AC.
I agree, you answered your own question. You said they're portable.
Yeah. It's not my decision. I can only give you my opinion, and I'm kind of old school. I'm not a modern tech guy, and anytime you call Athena to get an answer to something, they send you to the portal to watch a video or take a training. So, try to build a report on a system that you don't understand off of video is not, I mean, I can change some brake pads off a YouTube video, but I can't do that with Athena. My brain doesn't work that way, so.
YouTube hasn't created a video for that yet.
Right.
Since the board is in support of the smaller, that AC was it? So I'd entertain a motion that's.
I think Roger made that motion.
So
Roger makes
Yeah,
a motion.
Roger made that motion.
Second.
Yeah.
All in favor?
Aye.
Opposed?
That is all I have for the board today. That's all.
Something that we really need to do on a yearly basis is to appoint a personnel committee, basically to review Dan. And any volunteers? Or do you want me to? Roger?
Yeah.
Anybody else? Okay.
For that personnel committee, do you want me to bring to that committee things of nature like I did today with the MA? Reducing that nurse to an MA position or refilling positions? That'd be part of personnel as a whole.
I'm not quite following what you want to do.
So the personnel committee is designed to review me and my position and how I'm functioning, I'm assuming. Do they also want to be part of the hiring process for the health department as a whole, or changing positions? So if we have a person leave, if they resign from their position, does the personnel committee want to be involved in getting that position filled again, essentially?
That'd be separate. To me, that would be a board. You bring that recommendation based on what you've been doing.
Just, okay.
I think in the past, we've let the department do that, and you've asked for volunteers to come on certain key positions, and people have done that. I think, on the other hand, like if you should leave, which we hope not, then I think the whole board would be involved in that process.
Okay.
So I think in this one, it's just specifically going to be to review your performance.
Okay.
And then we count on you and the department to do all the rest of the reviews.
Any other questions?
Any other comments?
Longer than normal.
Entertain a motion to adjourn.
Second?
All in favor? Aye. Opposed? Thank you, everyone.